of hip scanning and hip effusion, and we've produced that as a scoping review. So we'll share this talk. So I'm just going to share my slides. Please just jump in if there's anything, if I go too fast or anything people don't understand. So this was a case only a couple of months ago, really. It's a good example of biases and keeping an open mind. I was in the department one evening and they asked me they said there's a 1.5-year-old with limp. So this boy had been back and forth to the urgent treatment centre and to our department 3 times over 3 days. And it went from, can you have a little look at this little lad with limp? And I was like, absolutely, I can. To a little bit of kind of confirmation bias of one of the nurses saying, oh, he's got a hot, swollen red knee. And I thought, well, that's all right. We can look at that as well. And he was a well lad, no relevant past medical history. And, oops, sorry. He looked a bit like this. He was eating one of these lovely jars, food all around his mouth, looked totally well, and did not seem to be limping, put it that way. His numbers were all fine, normal temperature, he looked happy, and I sort of said to the parents, how long has he been limping for? And they sort of said, well, he's not really limping, to be honest, he's just standing a bit funny. And he was just really held sort of on the end of the bed, still stood, but with his right leg slightly flexed at the hip and slightly off the floor. His examination of his hip was completely fine. So I did kind of what I would always do, which is to sometimes maybe lead with the probe when I know I don't want to upset a child and can get a fair bit more information just from scanning. That is obviously our examination, isn't it? So this is how you'd scan for a hip, so in a baby and in a child. High frequency probe, kind of aligning up on the upper femur at the articulation of the femoral neck. It's dead easy. And this is how it looks. So this would be the normal appearances, all right? So we can see, can you see the pointer?
Yep.
Spot on. So we've obviously got the sort of bony articulation with the physis, the epiphysis here. So an unfused in most children, up to the ages sort of 10, 11, 12, this is how it looks. And then we're really looking at this kind of part of the femoral neck here that articulates with that. And the bit of interest is the overlying capsule. So the normal dark material is sort of anechoic stuff here is just the normal joint space synovium. It can sometimes look a little bit speckled, but this capsule wraps around it circumferentially, and scanning for hip effusion is dead easy. Really, all you're looking for is whether this capsule remains kind of concave or sort of fills out and becomes convex. And we've got some good examples of that in the talk as we go. And it was decidedly normal for this kid, totally fine. So he scanned his knee, and I thought, I've got a couple of knee cases today, so I thought I'd just do a quick foray into the overview of what I'd look for with knees. This is obviously not him. With a knee, you're looking for a few different things. I've sort of expanded what I look at over the last few years from just sort of simple effusions and fluid, and I was shown by a couple of MSK radiographers how they do it, to maybe look in a bit more detail. I had a girl who had a meniscal tear about a month ago, and she was only 11. Initially scanned her for an effusion and then sort of had a little bit more look around and then figured that the issue was coming from a meniscus. So I've tried to sort of expand my repertoire a little bit, because I guess I don't want to miss that in the future. Obviously, we would always follow that up with, MRI imaging, but yeah, you can sort of add bits into it. So I'd start in the suprapatellar region here. So this would be this on this side of this image would obviously be proximal, this would be distal. And we see the subcutaneous fat here, and we see the kind of, I guess at this stage, the common quad tendon coming in. There's this region called the suprapatellar recess. It's a bit confusing. It's also known as the suprapatellar bursa, but I've had a lot of discussions with our orthopedic team who know I do a lot of scanning and a lot of involvement with them, as you'll see over these cases, asking them about what this space is, because it's not really like your average bursa that sits indistinct around the knee, infrapatellar, prepatellar, pes anserine. It's sort of more like a space, really. It's hard to explain. It confused even the orthopedic doctors who are consultants who are talking me through, who do the operations. They were like, well, there's a membrane, but it's connected in around 85% of cases. And normally it's just sort of, again, quite indistinct, quite flat, but it's not like your average fluid-filled bursa that sits there and can fill up in bursitis. It's more like a space, if that makes sense. Anyway, this is where fluid would accumulate when we have an effusion. So this is the long section. We've got the kind of prefemoral fat pad. Again, another graphic of it. And basically, effusion is very obvious. It fills this region up with dark anechoic material. We then rotate the transverse and we see the same thing. So we see the rec femoris here. We're coming sort of from kind of proximal to distal, kind of scanning up and down. Kind of got the vastus lateralis, vastus medialis, intermedius, and they form a common quad tendon at the end. And again, fluid will just be in between this space here. And it looks really, really obvious, to be honest. And then you can look infrapatellar. You could look at the patellar tendon. Does it look normal? Does it look intact? We can look at Osgood-Schlatters. It shows quite well, really quite clearly for POCUS. You have a fat pad in and around the lower part called Hoffer's fat pad. And again, you can just see accumulation of fluid within this space. Medially, I was talking to you about the meniscus. It's this triangular-like structure. It should look uniform all the way, no kind of raggedness or tears, not surrounded by fluid. You can even look at the collaterals. And then again, laterally similar thing, with the lateral meniscus being slightly different in shape, and the LCL can be overlying. So that is what I might do if I was looking at, say, a 15-year-old with a sports injury, just as an initial starting point, whether or not I need to refer, involve orthopedics, or do MRI. But back to our little lad. So he wasn't limping. He definitely didn't have a hot red knee. He had a normal hip and normal knee POCUS. So it was all a bit odd. He was eating, he looked fine, as I said. And basically just something about him on his right side that just wasn't quite right. He was sort of kind of flexed at the hip slightly, not flexed like, you'd see in a septic hip. Clearly he didn't have effusion, so I was happy with that. So I thought, let's have a think and a bit of a look around. So I put the probe onto his abdomen. And this is what I saw. So if any of you started doing any kind of abdominal POCUS, obviously fast or looking more at kind of right lower quadrant stuff, which is the stuff we're really interested in, this is all just grossly abnormal. So I knew this was bad news. It was really weird because the child looked so well. Even obviously I'm struggling to kind of describe the anatomy to you. Clearly here we've got a kind of a loop of bowel there, which is separated from this central kind of mass. Now this is really bright and echogenic. None of this should be here. And basically I knew that this was like kind of fat wrapped omentum. And whether or not we can see something within it, you see a circular structure here. I certainly can't make out a definitive appendix, which is obviously on the right side, what I was thinking about. Here, where sort of with the curvilinear probe, we're sort of fanning down. You can see the aspect of the bladder just here, kind of at this aspect of the image, and all of the rest of this is just grossly abnormal. All right. We've got like a kind of loop of bowel here with some shadowing behind it, but everything above is just very bright, shouldn't normally be there. It should just be normal collapsed bowel loops, just peristalsing slightly and flattened. So I thought, this isn't a hip at all, this is his abdomen. Anyone who works with me, I don't know who's on the call because I've not had a good look at the chat, but anyone who works with me knows I'm not really a blood sort of person a lot of the time. I just never fit them into my approach with a general patient. I'll more do them in this scenario when I'm really worried about something odd going on. So someone told me to do the bloods. Sorry, a few more images first. So this is an example of the normal views that we should get at the right low quadrant. Sorry, I forgot about that. So this is, we've got either kind of subcutaneous fat, usually above it, and then abdominal wall. So kind of rectus abdominis or external oblique muscle. And then beneath it, you've got kind of peritoneum and loops of bowel, just swirling away, churning away, but looking quite nondescript. Here's an example of what we'd be looking for with a normal appendix. So we've got iliac artery, and then you can't quite make it out here, but either sort of there or sometimes more medial is the vein. Put color flow on and see the artery and vein. And we're looking something projecting from the cecum region, which is going to be over here, more laterally, a sort of blind ending, loop, non-compressible, sort of typically kind of thin-walled and thin overall. So this is 1 centimeter. So this whole thing will be about 0.4 of a centimeter. So that'll be a normal appendix. And there's either the sort of external oblique or rectus abdominis. So I knew that something was unusual. So did this guy's bloods. And this is what we saw. Quite impressive for sort of quite a well child. And in essence, based on the scan, I was worried enough to think, this isn't anything MSK. This is definitely going to be his abdomen. This is almost certainly an appendix, could be a Meckel's. but he needed to go to our tertiary paediatric centre, which for under fives we would always do. Remember, this child was only 1.5. So this whole case was really quite interesting, more so because he came in with limp / refusal to weight bear / a hot red knee. I think it's just a good example of using POCUS to give a really good overview of maybe other things. Whether bloods alone would have been enough to help us make a diagnosis here, I don't think it would have been really. So he got the right treatment, and it was a nasty appendicitis. Okay, second case. So this was a guy, a little boy a few years ago, who came in with some knee pain and a bit of limp. He was well with a normal background. And when he was first seen, he had a mildly swollen knee, but it wasn't hot or tender. He was able to weight bear. He got some x-rays, which, I mean, you could maybe argue in his age group how much it's going to show you, but I guess theoretically it could be bony injury, could be non-accidental injury, anything of that nature. But they were pretty unremarkable. Possibly slight sort of effusion there on the lateral, isn't there? But not reported as showing much. And he also got some bloods. He was seen by the orthopedic team, who sort of in the notes they described it as transient synovitis of the knee. Just obviously beware with that term. That's not a term. That's not a thing actually. Clearly we can get a reactive synovitis of any joint, but it's not the same kind of regular recurrent pathology of a transient synovitis of the hip that we know resolves and was probably much more benign typically. So he should prove that he was not benign when he returned 3 days later, and this was my first time seeing him. So I reviewed him, and he had worsening pain. He was certainly limping at this point, and he'd also had a fever. So I put the probe on, and we'll talk through some of the images. So this is transverse, and this is what I was saying about the suprapatellar region, where we've got femur, we've got some subcutaneous fat, and we can possibly just work out a little bit of overlying muscle there. So you can see this massive space is filled with kind of anechoic fluid, but actually it's quite echogenic internally. It's what we call a complex effusion. Same thing in long section. So there's the articulation of distal femur. We talked there about the subcutaneous fat, overlying muscle, hard to say which one it is. And again, just a bit of really large effusion relative to the size of the child, as you can tell, with some septation within it. And again, fanning through, same sort of appearance there. There's the normal sort of synovium here, the normal speckled sort of joint space I was telling you about. And there's that suprapatellar sort of pouch or bursa, if you want to call it that. So dead abnormal. And he had a temperature, remember. Again, just another diagram, because I like simple diagrams. POCUS is really good for getting you to go back and look at your anatomy. I did I've done it loads and loads and loads over the last 5 or 6 years. Because we don't do much anatomy in med school, sadly, do we these days? So there's one of the potential spaces for accumulation in and around the sort of fat pad. And again, some of the other normal bursa where we'd expect if we had a classical bursitis, where it's a membranous kind of, fluid-filled sort of sac that can fill up. So this is where the sort of collection or effusion was. And this is what I wrote whenever I do these talks. It's copy it exactly how it is from the notes. So large hyperechoic complex right suprapatellar effusion. 1.7 is really, really big. I think even a few kind of millimeters, 0.2, 0.3 is decent on the screen on a small child. So 1.7 was huge. And I got a sort of slightly strange response, which was this: he can't be septic arthritis because he's not septic. I thought that was a strange one for any of us who manage kids in the PZD or on the ward. Nonetheless, we did his bloods because we knew something was going on, and he did have some moderately sort of elevated inflammatory markers in terms of ESR and CRP. And what happened next was sort of a bit unsatisfactory for him, really. So he was on the ward, and I'd kind of noted down my findings. The orthopedic team are really supportive of POCUS in my place on the whole, and are really good. But they needed a bit more information, ideally. Whenever I present this in other groups or in a group with some people from the east coast of America and Canada, Wednesday and the Thursday, the sort of first question was, why didn't you just put a needle in it? And sadly, that's not massively commonplace, I guess, direct from the PED, certainly in our department, maybe in the whole of the UK, but maybe that's somewhere where we might be able to move towards with increasing use of POCUS. So he didn't manage MRI sedation on a few occasions, so he didn't get that, and it wasn't felt that there'd be a great deal of benefit for repeating their radiology ultrasound. So he was just observed really on oral co-mox, and yeah, a bit of a funny one. He just he got better and he was fine. His temperature settled and all of this settled. So this is probably more like an infective kind of bursitis, sort of an infected collection rather than a true septic joint. Given that he improved so readily and didn't require washout. But yeah, just thought it was another good example of a pickup because that child came in with a limp. He was labelled as one thing, developed a temperature which sort of made him more interesting and returned. And thankfully, we were able to pick up kind of what was going on for him. If there's any questions, please just jump in. This was a 2-year-old girl I was asked to look at in the PCD who just was refusing to walk. So she'd been to nursery, completely fine that day, and then subsequently was just intermittently weight bearing, seemed really settled at rest, no pain, no systemic symptoms, but just wouldn't walk. So when we examined, there was no lateralizing signs at all to speak of, really. So, I would always scan sort of joints. I'll obviously examine as well. I'll, assess range of motion, which was fine, but it was weight bearing was the problem. So I think this was just a nice example for me of being able to probably add a bit of an extra layer of information rather than, do, I guess, the full legogram of X-ray. If it's a child of an age where you are going to X-ray, so 2, you could argue is a bit young for anything more sort of bony pathology, but of course for fracture we'd always want to rule something out. But we wouldn't want it to have a kind of the classic legogram, the foot, the ankle, the lower leg, and the femur and the pelvis. So just ran the scanner over it. And again, this is the distal femur, so we've got the kind of overlying kind of, I guess that's quad tendon there. And just this cortical defect here in long was present, which was also that kind of little, that kind of, I was always taught with x-rays, in our children, our age group, any crinkle, any crumple, we should always consider, it's normally a fracture, isn't it? Same thing on ultrasound, so just this articulation, and then this in transverse was the same thing, with possibly a little bit of surrounding inflammation. So we had no clue as to what had happened with this girl, what had gone on, why she was. I didn't even really know left or right initially, but this was on one of her legs. This was her X-ray. I don't know how many sort of on the call in the group would say they could pick anything up from that. I just think this is a good example of how things in the department can. One of the junior members of the team might undertake an X-ray, might get missed. It was more obvious on the AP, and we had just this. So this is what we were seeing. So obviously in this age group, you're thinking, okay, we've got a femur injury. Is this potentially something concerning, NAI or not? And we basically went back to the nursery. I don't know if I put on the slide. Yeah, I haven't. And Mum spoke back to the nursery, and they said that the only event was that she'd been pushed around in a toy car by another child at the nursery, and her leg was sort of hanging outwards and had gone through the door, and she did have a very brief bit of pain, but was fine immediately thereafter. So yeah, we were able to put that together and think with a minor injury, we weren't too concerned about anything worrying, but just thought it was a nice example of how I had no clues going into it, and we were able to pick that up just from having a good look with the probe. This, don't know if people have done much kind of looks around at the femur, but this is all quite grossly abnormal. It should be a nice smooth line all the way across. So that's just a classical cortical defect, like a buckle, just like what we see on the X-ray. Okay, this is a colleague's case, and we wrote some of these cases up as like a case series, and this is a nice one from my colleague. And this was a child with a left young boy who was going down a slide and got kind of the left foot or ankle caught. Does anyone on the call, anyone able to either put in the chat or comment what we think might be going on here? Anyone who does a bit of PEM? This mechanism is really classical for one type of injury we always see. And the clue is we don't tend to see it much on X-ray. I know everyone knows the answer, you're just shy, but so yeah, this always be the really common mechanism for a toddler's fracture, going down a slide. So these were the X-rays, and I couldn't see anything. We don't often see toddler's fractures. We just have to treat as presumed. They were reported as normal. But then my colleague looked with his probe and saw this nice little cortical defect, sort of lower third of the tibia, which I thought was nice. And child was managed as a toddler's fracture. and returned. And again, got this bigger version. Had this really lovely example of a callus. So I don't know if people follow up X-rays. We do it in clinic occasionally, where we see a really nice example of a callus formation showing that there has been a fracture there, and this is the sort of bone healing. I don't think this linear appearance here is the fracture. I think that's just the sort of artifact that we often get. Because that would be obvious if it was, but we often see this, don't we, in children? But yeah, nice example of a callus. So it was a good one. And then it's a case I think I've shared before in other talks where I was asked to look at a 5-year-old who was refusing to weight bear, and he'd been seen 3 times before this, whereby he'd stood on something sharp in his bedroom and was presumed to have obviously injured it, and a concern about potentially a foreign body. But he'd had a series of X-rays, all of which were normal, 3 sets up to this point. But when I saw him, he did have this unusual lesion on the bottom of his foot, which was a granuloma kind of appearance, telling me obviously something definitely has to be going on if it's been continuing to have issues for 4 weeks. So second set of X-rays that we saw, probably see the sort of wound at that stage, still healing, but definitely no evidence of foreign body, all reported as normal. And I was asked to scan his foot. Images all shared with consent have been published, and the dates. And this was this appearance that I saw. So I'm coming across something kind of end on, not quite long and not quite transverse, bit in between. But this is really big. Like, this is huge. You can just see from the width, bigger than your average little speck of glass or something. And these were the rest of the images I got, which we couldn't believe. Pretty massive, like 2.5 centimeters and maybe 3 in oblique. So you can see the kind of calcaneum there, base of the foot, and this large kind of linear, inorganic looking object. And in essence, this is what they pulled out of his foot when we talked to the orthopedic team. We were able to show them the images, obviously explained the X-rays were still normal at this stage, but we'd definitely seen something. And these are the big surgical scissors you get in theatre, you know, the huge ones. So you can see the massive size of this piece of cocktail and barbecue skewer sort of thing, thick wood. So that was a nice one. This was a 10-year-old girl I saw who came in who had some swelling of her ankle and had it on and off for 10 days. Sort of maybe borderline for temperature, wondered whether she was going to have some low-grade temperatures. And this was just a nice example of examining an ankle, not really being able to add much more with clinical exam alone. You know, she still had a range of plantar and dorsiflexion. So this is an anterior view. All right, we've got the kind of tibio-talar region here. Probably anterior part of talus. We've got the anterior tibial artery there, and we've got some of the anterior tendons there and there, and the overlying kind of skin and soft tissue. Nothing much there in terms of skin for like a cellulitis, but I don't know if you can see this sort of space here on the affected side is very different to the unaffected. So this was a good going ankle joint effusion. And I shared this case because it's just really nice showing all the different views. This is coming from the medial side. So again, it should just look like this. Everything's flush and contiguous with the sort of overlying tendons. Can pause that, might be easier for you guys. And then just this anechoic fluid collection there. So same on the lateral side. We've got a good anechoic collection with maybe a little bit of early septation. Whereas on this side, it's just a tiny little, not even a space. It's just everything's flush. So it's just a really clear example of an effusion. And then more posteriorly, trying to come around, just showing that this is basically a circumferential collection around the whole of the ankle. So I just asked orthopedics to come, and I really just showed them what we were seeing, that the ankle didn't look like that much clinically. She did have some good raised bloods, which helped. And yeah, she went for an MR, and she had this sort of subperiosteal abscess with the significant tibio-talar joint effusion. So she was managed as an osteomyelitis with subperiosteal abscess, and grew staph in there, and did all right. That was quite a nice, quick and easy one because we got it all sorted out within a few hours. This was another ankle of a 10-year-old boy who had Crohn's disease, and he was on a MAB and he was on methotrexate. So I guess you call him immunosuppressed. He had 7 days of pain, no trauma, and it was a swollen ankle, but wasn't tender, wasn't hot. There was, you know, there wasn't much to find. So we had some x-rays initially, which didn't reveal anything. And I'll just take you through these images. So again, this is the lateral aspect of the ankle, a bit like that last view that we saw, with some of the bony contours present. And this is, I guess, up here on this part of the screen is this sort of tibia-talar sort of region there, small effusion. I don't know if anyone's done any soft tissue soft tissue ultrasound generally, but there's some early kind of cobblestone in appearances here. You know, this bright kind of hyperechoic echogenic material. You see the sort of interlobular sort of fat glows very, very bright, which you see there, giving that cobblestone appearance with fluid levels in between. So it's a good example of cobblestoning. But the main finding, I don't know if anyone's aware of this, but these, when we see them, so the lower two images, these tendons coming down, so these would have been kind of the peroneal tendons on the lateral side. They're really quite abnormal. See this circular hypoechoic kind of thing around it. That's a fluid collection around it. And that shouldn't normally be there. They should just look flush like that we saw maybe on the other girls' images. So this is kind of like edema within the tendon sheaths. Again, there's not really a massive joint effusion to speak of or anything. So, and there's more skin and I guess it's more external. So I thought this was the source of the problem, kind of like a tenosynovitis, but I'd never had one before. So this was just my first example. I had to communicate what I was seeing to the orthopedic team. But yeah, they were really good again, and they understood that it was kind of what I was trying to communicate to them. So we went for an MR that afternoon. Let you read it. Small joint effusion, and then increased fluid signal within the tendon sheaths of peroneus longus and brevis, tenosynovitis. So I thought that was nice, and just another example of other things you can look for when you've got acute refusal to weight bear. Won't always be joint effusion, won't always be just simple skin infection, but if you build your repertoire up into looking for other stuff, it can be really helpful. This might be one of my last cases, you'd be glad to know. This is a 9-year-old girl who came into the department one evening and had been at ballet and had done a move and felt a crack of her leg and looked pale, looked like she had a significant injury of a thigh region, really. And the concern here was just we couldn't really immobilize her in order to get an x-ray. We couldn't get a plain film done in the department. We'd have to get around to the department, but she was in so much pain, even following intranasal fentanyl. So the options were going to be to undertake a ketamine sedation and consider splinting her, or to obviously consider doing a block, which I'm sure you know followed. But we didn't have any x-rays, so we didn't have a definitive injury in order to justify doing all of that to her. And the department was unsafely busy at that stage. It was kind of right during the time of strep when everyone was coming into the department, like I think it was 2 or 3 years ago now. And I'd already stayed, and maybe a couple of hours later than I should. Me and my other colleague were on, and we just didn't have the manpower and the kind of nurse and resources to be able to safely do a ketamine sedation there and then. But so we needed to know what was going on. So we just used POCUS to have a look at the bones. And this is her quad in longitudinal with the two sort of muscle bellies there, sort of overlying, kind of rec fem or vastus lateralis, depending on where we are. And you see these two glinting surfaces of the bone there and there, large hematoma there. And then as I slide down, you see this other aspect of the bone there, clearly fractured. Same thing in transverse. So again, we've got the muscles all linking up, the sort of 3 of the 4 muscles there. And then normally what we should see for a bone running down the femur is just a really smooth, basically that appearance there, cylindrical, completely untouched. And we can clearly see there's a significant fracture with a step with these bony edges. So we had our answer. So I thought, yeah, definitely we'll crack on and do the femoral block, which I did. Just me doing the block. So we've got the kind of approach from lateral to medial. We've got femoral artery and vein, and we've got this kind of hyperechoic triangular structure in here, which is where the nerve is going to be. I want to come beneath the 2 layers of the fascia, where that kind of fascia lata and iliaca kind of envelops the femoral nerve. So to do a good block, you really need to sort of split the 2 layers and keep away from the nerve here, but get very, very close, get close to it, but don't injure it. So there we go. You can see we've sort of hydrodissected down there and really enveloped it, and we're miles away from the vessel, so it's a nice safe block. And it was really nice. It worked well, actually. I went back in and she was singing songs like nursery rhymes and stuff with her nana, which was really nice. Made us feel good that I took away a pain and helped. And then once we'd done the block, we put her into a Thomas splint and finally got some X-rays to confirm what was going on. It's a nasty fracture. So again, this is what I would do every time now, actually. And I must admit, I've had no issue from our orthopedic team. Lots of support from them, sort of managing it in as efficient way as I think I can, depending on what the patient needs and how busy the department is. But I think always moving them and trying to mobilize beforehand, if it is a femur fracture, is always tricky. So I think I'm happy to just start by doing this and then probably do the block in most cases. So yeah, there we go. This was just last week, so I've just put this in as a final little thing. And I was asked by one of the orthopedic consultants to kind of scan a hip. So a child was in clinic, was known to have a DDH, had been in a harness, or then a surgery. And it's just a good example of how POCUS can help, really. So I don't know if you look at this X-ray, a few people got twitched by it and saw this sort of large overlying shadow, I guess, on X-ray. And was this something? Was this a hip effusion? She'd been restless apparently when she arrived at clinic that night, and two and two being added together, there's some concern. Is this something? Got asked to go around and have a look at her. And I did. I was just copying it from the notes, and I just said straight away, no hip effusion, and there's no issue on the left side in the skin or the soft tissues. It all looks normal, and actually she seems fine. So I just spoke to the consultant, just said, yeah, we'll just do everything you're going to do as normal, but this is not a hip effusion. And this was reported as a query hip effusion on X-ray, but we know that's not the best modality. So I don't know what caused this, but it was completely normal. So that was nice. So talked a bit about hips. I'm just going to wrap up now before I hand over to Nigel. This is how binary it is. This is the kind of unaffected to affected. This is what it looks like, and we loved doing hips. It was our first big game changer in our department that was just so quick and so easy to do, and the parents really kind of appreciate seeing an effusion on the screen, seeing the reassurance of it disappearing. So just last few slides. Just me talking really a bit about the kind of normal patient journey that we see. I don't know if this is familiar in anyone's department, particularly PEDS emergency department, where a child gets a legogram, and it's honestly none of them are needed because it's a 1.5-year-old. So unless you're thinking significant trauma or NAI, they don't need any of this really. And this is all they need. Just a quick scan, shows the effusion, move on. And these are all of the differential diagnoses that NICE put forward for a limp in a child. Some really important, serious stuff there that we wouldn't want to miss. Some potentially, devastating diagnoses that we'd want to identify very early. But if you put a probe on and you find they have a hip effusion, well, most of this can be ruled out. They don't have ALL if they're limping and they've got a hip effusion. Obviously, take into context the background and everything else. Do they look well? Do they have pallor? Have they lost weight? Clearly. But if none of that's the case and they're just limping and a GP's queried, could this be a malignancy? Well, you identify a hip effusion and you move away from that very quickly, which is good. So there's lots of reasons why POCUS is good for limp or good for, most of it's going to be hip issues we can identify quick and easily because it's quick, it's dead easy to do, it's non-irradiating, and it's very, Nigel talked to you a bit more detail about how it performs for picking things up in terms of hip effusion. But we also think about how non-specific a presentation limp is, a bit like some of the cases I've given you. Hard to zero in on, is it the hip, the knee, is that which part of the body is it? And it could be non-MSK presentations such as ALL, AML, could be torted testis. We've had in our department where someone asked us to, child was about to be being listed for theatre, big lad with autism, as a query kind of scrotal problem, and he sort of didn't seem to fit, and people have been back and forth different specialties, and me and one of my colleagues went down and scanned him and he had a hip effusion, and we just said, like, look, this is, I don't think this is the scrotum. This is, don't take him to theatre, don't rush him to theatre. And he didn't need to go. It wasn't a torted testis. So I think POCUS does this. It can help confirm the site of the etiology and exclude non-hip causes. and we've demonstrated for a few studies that it can limit unnecessary X-rays or bloods, when they're really not needed, such as in a well 1-year-old who's not being febrile or who you're not worried about. So Nigel's going to look at some of the evidence now. He'd included a paper we did, so I'll just quickly gloss over it now, and then he doesn't need to critically appraise how bad our study was when he talks about it. Probably some of you might be asking, kind of, how do we use hip effusion and what can we infer from it? Well, there's no test, there's no sort of study, on Earth that can tell you the content of the effusion, not MRI, nothing, not ultrasound. So we're trying to understand if we have a hip effusion, how can we make a decision about what that means? And the way we do that is with like integrating a clinical decision rule into that. So basically, this was just a little study we did as a pilot where we looked retrospectively at everyone's journey with limp, and we looked at those who'd had POCUS and those who hadn't, and we applied a clinical decision rule that we made up, which is, if I remember rightly, had to be between the ages 1 and 10. So what we're trying to do is understand if this can fit with a diagnosis of transient synovitis and nothing else. The reason we picked age 1 and 10 was because obviously underneath those ages, 8, 9 months, clearly that's not a common presentation for transient synovitis. The few I've had a few at 10, 11 months with septic hip, just because for whatever reason they tend not to really get transient synovitis the way a 3-year-old will. Same if they're 12-year-old, 11-year-old, they're unlikely to have transient synovitis as a primary diagnosis. So they had to be still well and weight bearing. They had to be afebrile and not to have features of pallor, lymphadenopathy, hepatosplenomegaly, and a duration of less than 7 days. So if we added all of those points in to POCUS, so you have a POCUS, you have a hip effusion, and you have all of those points, could we make that into a diagnosis of transient synovitis? And it was nice. It was sort of 96% accurate. And there was only a couple who just slightly fell out of that range, who were just a duration of 8 or 9 days, but they were actually still transient synovitis. And I think there was someone who possibly had fever as part of the story, but didn't actually have a fever. So it fit really quite well. So this is kind of maybe something we could look at as a prospective piece of work, looking at how do we use POCUS to make an actual kind of a reliable diagnosis. So yeah, that was our study. And I'm going to hand on to Nigel now. If there are any questions about any of those cases, does anyone want to ask now? Or if not, can do it at the end. Don't be shy. Okay, Nigel, looks like it's up to you.
Cool, thanks. You move the... Okay, so I've got the great job of talking about some literature, which is very hard to make engaging over Teams. So I'm just going to give you a brief overview of a bit of work that I've been doing over the past year or so, looking through the literature for studies that looked at the role of POCUS to pick up hip effusions in kids. And I'm going to split it up into these kind of 3 categories. So studies looking at the diagnostic accuracy, 2 papers that Dave's just kind of touched on, using it as a decision rule to help rule in the diagnosis of transient synovitis, and some smaller studies that have used it to aspirate hip joints for suspected septic hips in kids. So this is quite a busy slide. So it's just to give you an overview of the studies that were included. At the end, there's a QR thing that links to all these papers if anyone, for whatever reason, is interested to have a deeper dive. But if we just kind of start from the left, so you can see the earliest kind of study was back in 2006 up to last year. Most of the studies were done in the States and Israel. One was a multi-center study that included Australia and the States, and one study Dave's just touched on that he's done. Most of them were small and retrospective, and you can see all these studies, the scans were done by non-radiology people. So if you can move the slide, please.
Yeah.
So just looking at kind kind of diagnostic accuracy study. So there are 4 papers that looked into this. This was one of the most recent, and the only one that's a multi-center study that was done last year. So it was done across 5 tertiary pediatric EDs, 4 in the States, 1 in Australia, between 2019 and 2023. And what they did was they wanted to find out how accurate point of care ultrasound was to detect hip effusions, and they used radiology performance scans as their kind of gold standard. So they enrolled kids who came into their department with either hip pain or an atraumatic limp, or they weren't weight bearing, and they all got a point of care ultrasound scan of their hips, as well as a formal radiology performance scan as the kind of gold standard for if they had an effusion or not. And they managed to enroll 161 kids, so 322 hips were scanned, and they had 18 different pediatric emergency doctors doing the scans. And what they found was they picked up 77 hip effusions with POCUS, and there were 75 that were detected with the radiology scans, which gave them an overall sensitivity of 89% and a very high specificity, as you can see there. It is worth noting that 3 of the 18 people did more than half of the scans. So they did do some kind of did smaller analysis looking at how accurate those 3 high volume users were, and their sensitivity went up to 98%, which just kind of shows that it is quite operator dependent, and depending on how experienced you are at doing these scans, the more accurate you are, as you would kind of expect. This one was a single center perspective study that was done, I think in Israel, this one was, back in 2020. And again, they did a similar thing, enrolled kids with a limp, hip pain, or not weight bearing. And again, they wanted to see how accurate point of care ultrasound was at detecting hip effusions. And they also used radiology scans as their kind of gold standard. So all the kids got both, basically. They managed to include 95 patients, with 8 different pediatric EM doctors doing the scans. And they had 49 hip effusions in total, and POCUS picked up 44 of them. And they actually did some statistical analysis on how what the agreement was between the POCUS scans and the RADA scans, and they had a Cohen's kappa coefficient of 0.81, which is very good, giving them an overall sensitivity of about 90% and specificity of 91%. This one, if you're still with me, is quite a big one, probably one of the biggest studies that was done. This was a big retrospective cohort study. They collected patients between 2009 and 2014. It wasn't quite a proper diagnostic accuracy study. So what they did was they did point of care ultrasound scans to see if they could pick up hip effusions. And they didn't all get a formal radiology scan, but all the images were reviewed by to what they called POCUS experts, and what their opinion of the final scan was whether they had an effusion or not. So again, same kind of inclusion. Children with limp and hip pain were not weight bearing. They managed to pick up over 500 patients over that 4 or 5 year period. They had quite a large number of people doing the scans. They had 72 different pediatric emergency trained. I think about half were fellows and half were attendings or consultants, because it was in the States. And their sensitivity was 85% and specificity of 98%. They also did some analysis on how accurate or how much better you got per scan. I think their accuracy was about 2.4%, even with the more scans you did. But as you would kind of expect, the more you do, the more accurate you are. And then can you move and then this one was a bit of a smaller study, but probably one of the first diagnostic accuracy studies that I could find, done in 2007. So much like the first 2, everyone got a point of care scan and a radiology scan as the gold standard. They included 28 kids who, again, were either limping, had weight pain, or weren't walking. They have 3 different people doing the scans, and their sensitivity was a bit lower, 80%, but again, a high specificity of 98%. This study was one of the, so I think it's fair to say that the study that Dave talked about that he carried out was kind of based off this study. It was done back in 2021. So they essentially used point of care ultrasound to help rule in a diagnosis of transient synovitis. So again, they came up with this new decision support algorithm, including ultrasound. So their age range was a bit different. So they included kids between 3 to 10, didn't have a fever, were able to walk, had symptoms less than a week, and were otherwise not unwell with these kind of other signs. So if they fulfilled that criteria and they had a point of care scan which showed a hip effusion, then they made a diagnosis of transient synovitis. And what they did was they followed up all these patients in about a week's time. And if their symptoms had resolved or they rescanned their hips and the effusion had gotten smaller, then they considered that a diagnosis of transient synovitis. So over that 5-year period, they enrolled 621 kids. They had 38 different ED doctors doing scans. And they had an overall sensitivity of 91% and a slightly lower specificity of 78%. So they're kind of showed that it's good for ruling in the diagnosis of transient synovitis, but if you don't have an infusion, it doesn't mean you can rule it out, which I guess makes sense because depending on when you scan them, they might not have an effusion at that point if you scan them quite early on.
That's true, Nigel. In that study, I think they had like 6 patients who were all presenting within the first 12-ish hours, 24 hours, and they cautioned about, if you're scanning too early, it's definitely a possibility that as soon as the child wakes up, they're not weight bearing, they come straight to ED, which happens a fair bit in our department. It may not quite be enough time to see the signs on POCUS.
Yep. And then finally, I'm just going to mention these 3. These are all slightly smaller, older papers, all retrospective, small case series between kind of 5 to 17 patients. And they essentially describe using point of care ultrasound to help make a diagnosis of septic arthritis and performing hip aspirations in the department. As Dave said, none of these papers were done in the UK. So it's not something that I think we particularly do, but it's interesting to see how other departments around the world will do other things. And essentially they just demonstrated that they're able to use POCUS to make a quicker diagnosis of septic arthritis and initiate management quicker, which you'd think would result in a better patient outcome. Particularly, they mentioned that, which is true for our site, you can't get an ultrasound out of hours, which can cause a delay in making the diagnosis. But I think, understandably, they're all very small retrospective case series, so I don't think there's been any big prospective studies to test this hypothesis, but just the worth mention. So if you want to have a look at any of those studies, hopefully that QR code should bring you to them. But essentially, it's pretty accurate for detecting hip effusions in children. So I've written the range of sensitivities and specificities there over those four studies. There's a potential that it could help you reduce doing blood tests that might not be needed or X-rays that might not be needed and make a quicker diagnosis. The caveat is a lot of these studies are small, single center and retrospective, and not many of them look at patient-centered outcomes or how it affects patient journey and cost-benefit analysis, which would be interesting to look at in the future. Okay.
Spot on. Cool. All right, guys, that's all we've got today. Are there any questions at all? Please don't be shy. If there's anything you want to ask about kind of modalities or anything anyone wants to kind of question or challenge even, I'll welcome that. Anything at all? Okay, that's all right. So yeah, thanks for coming along. We do this every month for those who are new. If there are any topics anyone would like us to talk about, you can put it in the chat or drop Nigel or me an email. We've got lots of sort of external speakers and stuff lined up, but always happy to take suggestions. If anyone would like to present anything or look at literature, you're dead welcome. Please get in touch. And if anyone wants to get involved with any pieces of work or studies, there's lots of stuff going on between Nigel and myself.
Can you see the chat? There was a question.
Oh, sorry. I can do. Right. Sorry, where are we?
The question was, do you ever see bilateral effusions on transient synovitis?
Thanks. Yeah, good question, Benjamin. So the quoted has been relatively high, don't they? The kind of quoted has maybe been like close to 10%. I'm going to be honest, we've done loads and loads and loads of hips. This was our real game changer where we had like 550 in our first study. We did like a little internal QI. So probably way more than that between me and a few of the guys who do it, because it is just so easy to kind of teach and do. I think I've probably only seen it about 4 or 5 times, to be honest. So I think, it is something that you can master pretty quick and use as just a part of a tool to either rule out or rule in. It's sometimes, I'm sure you've seen this yourself, where we don't even know, is it left hip, right hip, sometimes the point. And I think either way, it can be just really reassuring to just add in. But yeah, probably only seen bilateral a handful of times. Can we also know any POCUS training sessions? So we have our POCUS Sunus course, but unfortunately the upcoming course is booked. That was at the end of February. It's just, if you Google Sunus, I'll put in the chat, SUNUS, or Sunderland Ultrasound Society is our little group. So we do a PEM specific course where we teach all of these modalities. I think we're the only one in the UK that does that. Kid models come in. Thanks, Nigel's posted it. But unfortunately, we were sold out pretty quick. So that's at the end of February. But we'll have another one coming up soon. You can check out the website. Yeah. Any other questions?